The CTEF have been, the pulmonary hypertension has been classified by the World Health Organization and refined recently by NIS. You see here that we have two categories, the pre-capillary and post-capillary hypertension, and the CTEF, the most important one for interventional radiology, for interventional is in the group 4, pulmonary hypertension secondary to chronic thromboembolic disease. Actually, this CTEF, this endovascular management include other techniques, arterial septotomy, pulmonary artery denervation, and balloon pulmonary angioplasty. The most important one again for us is the balloon pulmonary angioplasty. The CTEF is, of course, a definition about hemodynamic consequences in terms of hypertension, but also some typical morphological changes induced by the pulmonary embolism. We estimate the prevalence of CTEF after acute pulmonary embolism at about 5%, and about 1/3 of the patients did not have historic pulmonary embolism when the diagnosis is come to be established. The prognosis without treatment is very bad. 10% of people die. 10% of people are still survive with pulmonary pressure more than 50%, more than 50 millimeter mercury after 5 years, which is really very bad. Now, the changes, morphologic changes in the arterial system or in 3 categories. The first one is thrombus itself, with some remodeling in the thrombus fibrotic changes, and this is what we recognize as a microangiopathy, which includes stenosis, webs, and membranes inside the vessel, and also total occlusion. It is important to understand also that the hypertension itself will induce some changes specific to hypertension, antemomedial thickening, some microangiopathy, very distal microangiopathy, that are not necessarily visible on morphologic imaging like CT, MR, or even angiography, but sometimes they are visible only in perfusion tests and could be very important to consider for the patient selection for treatment, specifically for endovascular management. And finally, the role of inflammation has been extensively discussed but not completely understood. Now, if we consider the morphologic changes and we integrate these lesions into the arterial bed, pulmonary arterial bed, we can distinguish between 3 categories. The first one is the proximal, the most proximal lesions accessible for surgical treatment, and this is what we call proximal pulmonary hypertension. And the distal lesions more than subsegmental level, distal lesions are not accessible to the surgeon, and this is traditionally patients which need with medical treatment. And in between, we have this category of lesion not too proximal for the surgeon and not too distal for treatment by drugs only, and we expect to have a solution for those patients by proposing another alternative, which is balloon angioplasty. This was what we established in 2018 from the beginning of extended indication of balloon angioplasty and pulmonary hypertension. Actually, this is changing a little bit. We try to extend more indication of PBE to more proximal lesion, and you will understand why this strategy is moving. Now, as we established the first indication as no option, no other option, medical treatment or surgical treatment, we have to have discussion to select those patients. And majority of cases, in majority of centers, we advocate the use of multidisciplinary team to make this decision. In Switzerland, we have this Swiss CTEF board to decide which patient should have benefit from pulmonary angioplasty. Actually, 3 subgroup of population are selected for this kind of treatment. The first group is patients unsuitable for surgery because the lesion is not accessible. This is the case for distal lesion, or because the patient is not operable in terms of risk benefits for the patient, comorbidities, mainly, or the reason for this subgroup. The second reason is the pulmonary hypertension, residual pulmonary hypertension after surgery, and this is about 3% of patients, which is not neglectable. And the last one is patient who decline surgery, and this group of patients is growing year after year. When we explain to patients that we have two options, surgery or pulmonary angioplasty, many patients will choose pulmonary angioplasty because it's less invasive and as efficient as pulmonary lumpectomy. The technique itself is old technique of angioplasty using just a balloon. From time to time we use a stent. The majority of cases is just a balloon. For distal lesions we use a platform of 14, for proximal lesions 18, exceptionally 35. And in general, the catheterization is done with a 3-axial system, guiding catheter and long sheet to cross the right ventricle and to position the sheet into the proximal pulmonary artery. The environment to do the PBE is very simple again. We do it in moderate sedation, avoiding full general anesthesia for those kind of patients. More important is to prepare patient for the reperfusion edema by using diuretic and corticosteroid before the procedure. In general, the procedure by decision of our multidisciplinary team is done with a short stay in the ICU or intermediate care, and the length of stay for those patients is in general 3 days. This is one example here. You can see this kind of lesion. This is a stenosis. We treat this by stenosis by standard angioplasty, cross the lesion with the guide wire, then the balloon. In general, we avoid to have 1-to-1 as we do in the arterial system. We underestimate the balloon for angioplasty to avoid complication. In case of occlusion, we use soft guide wires for crossing the lesion. Exceptionally, we use dedicated CTO guide wires. There are some refinements in terms of selecting the lesion and optimizing the treatment using IVUS or OCT, but it's still limited in terms of number of patients needing this type of refinement. In general, it's relatively easy to do it with a simple guide wire and simple balloon. However, navigation through this vessel is very difficult and need some learning curve. Of course, the stenosis are more easy to treat than the CTOs. What about the outcome? The first question is the comparison between this treatment and the surgery. Of course, also there is no solid evidence and there is no randomized controlled studies, but if we compare the effect of pulmonary angioplasty in Russia, pulmonary resistance and the cardiac index, we can see that all are improved after angioplasty in this meta-analysis. Functional test, 6 minutes walking distance is improved also in this meta-analysis. What about the surgery? We are doing similar to the surgery and probably certainly less complication than surgery, specifically those related to the pulmonary edema. If we do the same comparison through a meta-analysis regarding angioplasty and the medical treatment, we can see also that we do similar with a little bit more complication due to invasive nature of the technique, but the functional improvement is better than the medical treatment. However, we have no randomized controlled trial, and we need more evidence to establish these statements. Complication, the most important one is the reperfusion edema after, and we have several statements or several rules to avoid this, to do this angioplasty through 2 or 3 sessions. The maximum I had to do was 10 sessions for a senior patient. We start with stenosis first, and we have also some other points to take into account for selecting the best vessel to be opened and to be successful. Unresolved issue, no randomized controlled study. We need standardization. We need also to have dedicated devices for this kind of interventions. In conclusion, this is a disruptive innovation. It needs specific skills and dedicated training. We need a multidisciplinary decision at the moment to select the patient. We have promising results, and the future developments are needed for the material, for how to guide intervention with the image, and finally for the patient selection. Thank you very much.
Thank you, Natalie.